Bismillah ar-Rahman ar-Rahim. So welcome back again. We'll continue with our today's lectures. So we'll start with Dr. Mukhtar Abdul Azim. He's an associate professor of orthopedic in Azhar University, and he's an expert surgeon in trauma and microsurgery. He'll be talking about posterior tibial plateau fractures, how to select my approach. Please, Dr. Mukhtar.
Assalamu alaikum. Imagine if you have this case, young patient, healthy, presented with this X-ray. What's your decision? You can get a fracture pattern from this X-ray, but it is insufficient to get more details to select your approach to detect what is the type of implant will be used. For this, you must use CT to help you to decide which approach, anterior or posterior. What is the position of my patient? It must be prone position, supine position. You need single approach versus dual approach, and the CT help you to decide and to do proper preoperative planning. Tibial plateau fracture are complex knee injuries. Treatments of such fractures traditionally based on the Schutzker classification, and this is old. CT scan allowed more detailed injury recognition and help in preoperative planning. Many new CT-based classification were developed. Anterolateral approach commonly used, but nowadays there is most newer approaches, either single or combined approaches. The journey of philosophy changed from 2D to 3D. The Schutzker start what's called the condyle concept, mainly dependent medial condyle, lateral condyle, bicondylar with shaft. Then more came with rim concept, concentrate in fracture dislocation and also fractures more proximal, more juxta-articular. Then new concept of three-column concept, and then quadrant concept, and the most recent one is segment concept, and we'll go in detail through this segment concept. And lastly, the Schutzker with his teams modify the Schutzker classification, what's called quadrant condyle concept by Kufuri. This is the Schutzker condylar classification and also Moore's classification. What is the wrong with this classification, or what is not good? Lower intra and inter-observer reliability usually depend on coronal plane assessment, unable to recognize all fracture planes, and this is essential for decision for patient positioning, approach selection, hardware selection also. For this, we will go to 3D concept. Nowadays, this is most accepted concept. Either column concept or quadrant concept, like this one. I don't know what is, okay. Yes, or segment concept, either 10 segment or 8 concept. Okay. New 3D concept advantage. Establish new anatomical plateau landmarks. Define the key of joint stability, either rim continuity or containment of the posterior wedge. Determine fracture plane wedge orientation. Our goal of surgery, like AO principles, respect soft tissue. You have articular component and metaphyseal component. Articular component, anatomic reduction, rigid fixation to achieve absolute stability. Metaphyseal component, function reduction. You must restore length, rotation, alignment, and then stable fixation to achieve relative stability. And also for healing of the cartilage, you must start early range of motion. Decision more important than incision. Assess your patient, comorbidities, functional demands. What's your procedure? You will go to single stage or stage procedure, 2 stage. This according soft tissue, or if this fracture is open or closed. Fracture geometry, joint depression location, condition of the posterior cortex. It is contained or there is shearing of the posterior cortex, need to elevate it, reduce it, and buttressing by buttress plate. Then your techniques regarding the approach selection, implant for choices, and fixation strategies. If you have patient like this, there is soft tissue problem. You will do single stage? No. You must do stage procedure, 2 stage. You will start by span to elevate the alignment of soft tissue, to elevate tension of soft tissue. Then scan, assess failure pattern, assess plateau map, assess impaction and depression zones, and then plan. And usually remember, fail to plan is plan to fail. Plan the time, approach selection, then implant choice and fixation strategy. Time plan, very important. In this case, please stop, don't do surgery. In this case, you are at risk. But nowadays, now you can go to do your surgery. Okay? How to select your approach? Soft tissue condition, very important. X-ray to detect failure pattern, either coronal or sagittal plane. Then CT to assess fragment location, joint depression, containment of the posterior cortex, if it is sheared or not sheared, and implant type. Our approaches, the most common approach used by most of surgeons, anterolateral approach. And there is classic anterolateral approach, and there is many modification for this anterolateral approach. Now we'll focus, we talk about posterior fracture tibial plateau, we'll focus about the posterior approaches. Posteromedial approach, either supine or prone. Posterolateral approaches, either with fibular osteotomy or without fibular osteotomy, or extensile approaches. And then sometimes the fracture is complex. Single approach is not enough. At this moment, you want to go to do dual approach or combined approach. Imagine if you have this fracture, you have wedge, and this wedge is non-contained, there is shearing. For this, you will select posterior approach, okay. But what about the position of the patient? It will be prone or supine. Prone versus supine. I think in this situation, you must do prone position, not supine position, to reduce the fragment and do buttressing blade. And this is the two approaches, either supine position and either prone position, and in this prone position you are unable to expose posterior shearing fragment, reduce it, and buttressing by blade. And this is what's called the Loppenhofer supine posteromedial approach. It is access the type 4 and some posteromedial extension. And usually we need to do figure 4. This is supine position. Okay? In this fracture pattern, you have posteromedial shearing fragment. Is this fracture pattern, is supine position is enough? No. In this situation, you must need prone position, posterior approach, and you must buttress this fragment and apply the buttress plate. And this is what's called the prone posteromedial approach, modified by Gala and Loppenhofer. Okay? Now we will go to posterolateral approaches. You have 3 approaches: supine with fibular osteotomy, prone without fibular osteotomy, and extensile, most recent approach by Frosch. Supine posterolateral approach need fibular osteotomy, and this is destructive. And the problem with this approach, proper visualization, but with high risk of soft tissue complication. For this, we'll go to prone posterolateral approach, modified by Shang and Tao. Prone position, access posterolateral fragment, explore the common peroneal nerve, and improve reduction and stabilization, and also the functional outcome. If you have fracture pattern, not posterolateral only, associated with anterolateral, is this posterolateral approach is enough? No. You need more. You need extensile approach. And this is described by Frosch, which access the anterolateral tibial plateau and posterolateral tibial plateau at same time. To lateral decubitus position, lateral incision, 2 windows, window access anterolateral fragment and another window access posterolateral fragment. And common peroneal must be explored and to take care to avoid traction on this nerve. Proper visualization, but also the problem with this approach cannot extend distally more than 5 centimeters, and this means not good for extension of fracture to the metaphysis of the tibia. In this situation, more complex. You have anterolateral fragment, posterolateral fragment, at the same time posteromedial fragment. Single approach not enough. Usually we need to do combined approach. Okay? And for this, we need to do combined approach to access posteromedial and anterolateral same time. And also we can do it either prone or supine. The another combined approach is described by Carlson. This is if you have posterolateral tibial plateau and posteromedial at the same time. Keep the patient prone position and do double incision on the medial side and lateral side to access bicondylar fracture. Also, the limitation is not extend more than 5 centimeters. The reduction was be easiest with the knee in full extension. My algorithm to select your approach is depend on the CT classification. This is segment classification. If the fragment affected anterolateral, lateral, posterolateral, lateral, you can use anterolateral classic approach. But if this fragment is go to more central, anterolateral, lateral, central, and the anterior central, you can use extended or modified anterolateral approach, or you can do it what's called fracturoscopy, using scope-assisted reduction. But if you have the fracture extended to anteromedial and a little bit posteromedial, you can select posteromedial approach in supine position. And if the more complex fracture extending to posteromedial, and this posteromedial is shearing the fracture. You need to buttress this fragment. You will go to do posteromedial approach in prone position. Lastly, if you have the fracture in the posterolateral, and this is area, very difficult area, and what's called the area of interest, you can use modified anterolateral approach, or you can use double posterolateral and posteromedial approach. There is many types of implant, you can use it, but the most recent one is rim plate. This is for the fracture more proximal or juxta-articular fracture, and also long lateral plate. Also, the function, they must determine what is the failure pattern. Failure pattern, either compression or tension. Your first plate L or T applied on compression side, act as the buttress, and second plate on tension side. And this is what's called the blade zone concept. Don't forget the fracture more proximal, you need to do rafting for this fracture, either by K-wires or mini screws to transmit the forces across the multiple raft screws or multiple K-wires. Also, you can apply plate, and this plate will take some direction, but there is missing, some fragment missing, like this fragment of this. Okay? You can use it by green line this by percutaneous screw from anterior to posterior. Yani you will approach anterolateral, okay, and apply the plate, and this yellow screws, this screws of the plate, and you need to do percutaneous screws from anterior to posterior. We do some examples for our cases. Male, 36 years old, twisting injury to the left knee, soft tissue is okay, failure pattern coronal plane, this X-ray is not enough. This is CT of the patient, mainly posterolateral fragment, location, joint depression, central, posterior cortex, shearing cortex. The implant I will use buttress blade to buttress this fragment. This is our approach. This is the sural nerve, must be explored to avoid the neuroma and the hypothesia. And then inverted L shape incision. Then exploration of the common peroneal nerve, and you are going between the gastrocnemius and soleus, and do detachment of the popliteus and hanging with the stay suture, and then apply your plate. And this is posterolateral plate and with rafting K-wire fixation. This is immediate postoperative. This is last follow-up, and this is the clinical photo of the patient, site of incision, flexion, extension, and this is the movie of the patient. Second case, male 25 falling from height on the left knee, presented by this pattern of injury. This very difficult situation. You have posterolateral and posteromedial corner, and this corner is shearing. The pattern of failure is coronal plane, soft tissue is okay, one stage surgery, fragment location posterolateral, posteromedial, central depression, posterior cortex is shearing cortex, need to be buttressed by plate. What we do in this case, we do what's called the combined approach described by Carlson, two incision, posterolateral and posteromedial, and then starting by the posteromedial side, and do reduction and fixation by plates, and then going to the posterolateral side, and this is the common peroneal nerve. And this is immediate post-op X-ray. This patient already polytrauma and already have elbow injury also. This is post-op X-ray regarding the plateau fracture, okay? And this is the last follow-up, and this is the clinical photo of the patient, flexion and extension, and this is a double incision in the photo above. And this is the video or movie of the patient. The third case, male patient, 41 years old, falling from height on the semi-flexed right knee, and this presented by fracture dislocation of the knee. The pattern of failure mainly in coronal plane. And this is CT fragment, posteromedial fragment. There is central joint depression, posterior cortex is shearing, and also we need to buttress this fragment, reduction and buttress this fragment. We do what's called prone posteromedial approach. And the nerve is a short saphenous nerve, very important to detect it to avoid the patient will complain from hypothesia in the anteromedial aspect of the leg. and this fragment is remove the fracture hematoma and try to reduce, and preliminary fixation by K-wires, then fixation by buttressing plate. And this is the post-op X-ray, and also this is last follow-up. The fourth case, soft tissue is okay also, failure pattern sagittal plane. This case is tricky case. What you will do, single approach, dual approach for this CT will help you. You have two condyles, medial condyle and lateral condyle, and posterior cortex, not shearing or non-shearing. For this, we need only to apply supporting plate, not buttressing plate. This is the our incision, anterolateral and posteromedial in supine position. And this is the post-op X-ray. And this is last follow-up. Our take-home message, plateau fractures can be approached either anterolateral, medial, or posterior approaches. Detailed fracture morphology analysis dictate the choice of the appropriate approach. Ideal surgical approach should allow visualization and fixation with minimal complications. A combined approach is ideal approach that leads to good functional outcome. Trauma surgeon should have the knowledge of the different and combined new approaches. Thank you. Also, I will thank this Dr. Mahmoud Zoghbi, one of my colleagues who helped me in most of this plateau fractures. Thank you very much.
Thank you, Dr. Mukhtar. So, do we have any questions for Dr. Mukhtar?
Of course.
Any questions? Okay, Dr. Ali.
Thank you, Dr. Mukhtar.
Thank you.
My question regarding the posterolateral approach.
Posterolateral approaches.
Yeah. How do we select if we want to do osteotomy between fibular head osteotomy or lateral condyle osteotomy?
You have fracture tibial plateau already?
Yeah, posterolateral.
Posterolateral fragment, shearing fragment.
Yes, and we want to expose more to see the fragment. Or we don't do osteotomy anymore?
No, I don't prefer osteotomy at all in the fibula because it's destructive. And my approach, if you have posterior tibial plateau fracture, and this posterior tibial plateau fracture is shearing, I need to do posterolateral L shape and then open fragment and depend on my reduction in the posterior cortex. If I have any central depression, I will open fragment like open book and elevate the fragment, botigraft, and then apply the posterior cortex, and mainly depend on the geometry of the fracture distally rather than articular component. Helped by image. Yes.
Thank you.
Welcome.
Any more questions? So thank you, Dr. Mukhtar.
Thank you.
So we'll proceed to the next talk by Dr. Mutwalli. Dr. Mutwalli is consultant orthopedic in Farwania Hospital, and he'll be talking about MIS calcaneus fractures, Farwania Hospital experience.
Assalamu alaikum. I would like to thank the organizing committee for inviting me to talk about calcaneal fractures and to be among this awesome gathering today. Displaced interarticular calcaneal fractures, how to get it right first time. I have nothing to disclose related to my talk. This topic, I think, is the interarticular calcaneal fractures is unanswered question till now, and the literature almost shows operative treatment have the same results like non-operative treatment, and the best available evidence are randomized controlled trials. The most famous is the Canadian trial by Buckley, 2022, and the Swedish trial, 2013, UK Hill Trial 1, UK Hill Trial 2. All of them show the same results, comparing the operative and non-operative treatment. But there is consensus that perfect reduction has a better patient-reported outcomes. Also, there is higher relative risk of subtalar fusion in the non-operatively treated cases, with difficulty in achieving reconstruction of the malaligned and malunited hind foot in interarticular calcaneal fractures. But there is absolute indication for open reduction internal fixations, which are almost excluded from the UK Hill trial, like this displaced tongue type fractures with soft tissue compromise. You cannot think either operative, non-operative, because the skin will immediately slough. In cases of open fractures, transcalcaneal talonavicular fracture dislocations with bad the stereonavicular dislocation fractured, the talus is dislocated through the calcaneus, and fracture dislocations where the superior lateral fragment is dislocated lateral to the fibular head. The worst scenario is OIF, is to choose to do open reduction and the internal fixation, but you fail to achieve satisfactory reduction and restoration of the external dimensions of the calcaneus. And like in this scenario, the patient got open reduction, internal fixation, the alignment of the hind foot is not restored, the articular surface is not restored, and the patient developed osteomyelitis of the calcaneus. The patient gained the benefit, the patient got the complications of surgery and the disadvantages of non-operative treatment. Another case, the patient has subfibular impingement with lateral wall blowout, with peroneal tendonitis, prominent screws, no articular reductions. The talar declination angle is not restored. The patient has anterior ankle impingement, lateral ankle impingement, difficulty with shoe wear. In Farania Hospital, since 2013, we started doing minimally invasive sinus tarsi approach for interarticular calcaneal fractures. And this is the position we used for our surgery in lateral decubitus. Before dropping, we start to teach the patient, the C-arm technician, how to take lateral view, how to take the axial view, how to take Bruden's view. And this is aided by the use of headlight source, headlight. This makes the job easier after covering the patient because the C-arm technician will be confused after covering. This is a case example. This patient is 41 years old. He fell from a scaffold and he sustained displaced interarticular calcaneal fractures with diminished calcaneal height, lateral wall blowout. And this is CT scan. The superlateral fragment is almost abutting the plantar surface of the calcaneus. The secondary fracture line is extending to the calcaneocuboid joint. And there is also fracture line into the syntacculum, the constant fragment. Before starting the surgery, this is CC-arm taking before surgery. We used to put distractor before opening a sinus tarsi approach. You put one calcaneal pin in the most posterior aspect of the calcaneal tuberosity, perpendicular to the malaligned calcaneal tuberosity, and the other pin in the distal anterior aspect of the tibia, just above the ankle joint. We start distraction to push the calcaneal tuberosity distally, posteriorly, and plantarly. This is after distraction. The calcaneal tuberosity is pushed down. The medial wall still there is a step after distraction and restoration of the length, but the calcaneal the varus in interarticular calcaneal fractures compose two deformities: the varus position of the heel and lateral translation. This is after distraction. Then we start to push the calcaneal tuberosity over the smooth pin medially to restore the medial calcaneal wall. And at this stage, we put two wires from the calcaneal tuberosity to the subsyntacral fragment or the constant fragment, keeping the depressed part in the middle of the calcaneus away from our fixation, because we will manipulate it after we open sinus tarsi approach. The distractor can be either medial or medial and lateral and do differential distraction. I do both according to the availability of the open compressor device. This is a sinus tarsi approach marked in the skin from the tip of the fibula into the direction of the fourth metatarsal base. This is the intraoperative photo of the after we open the sinus tarsi approach with using the head light source. This is after we reduce the articular fragment or the superior lateral fragment to the subsyntacral fragment with the calcaneal tuberosity pushed away distally and backward, and the anterior process is reduced, and all are fixed by percutaneous wires. My advice is not to trust the lateral view of the calcaneus to assess the quality of your reduction. The best thing is to go through the 4 degrees of Bruden's view to see if there is an articular step, because the superlateral fragment is almost always rotated and depressed. If you elevate it without derotating it, you will get step, especially in the posterior part, which is clear, and the 4-degree angle of the Brodens view, which is difficult to see by your eyes, even if we're using the headlight, because it is immediately medial to the peroneal tendons, behind the fibula. This is the 2nd degree, 20 degree of Brodens view, 30 degree, and 40 degree, and lateral view. Now, we are sure the articular surface is reduced, temporarily fixed by Q-wires. We'll start the definitive fixation using the same wires for definitive fixation by cannulated screws, fully threaded. There is no place for leg screw because we need to keep the position we achieved. The strategy of our screws is 1 screw from the calcaneal tuberosity to the, or 2, even according to the size of the fragment, from the calcaneal tuberosity to the sustentacular fragment, from the calcaneal tuberosity to the anterior process. In addition to key wires, if sometimes you have small anterolateral fragment from the anterior process, which is not, I find difficult to put screws through it. The most important thing is the transverse screws from the superior lateral fragment into the sustentaculum, which is technically, even in my hand, I feel it is challenging to target exactly this small piece of bone, which is the most dense, and you depend on it for your construct. After fixation by cannulated screws, I remove the wires. Here I keep 2 wires holding small fragments, which are not candidate for 3.5 screws. This is a case example. This patient is a construction worker. He fell from a scaffold, and he sustained displaced interarticular calcaneal fracture. The CT scan showed this is Sander type 3, and the middle fragment is fractured in the coronal plane, anterior part and the posterior part. In these cases, I found a challenge to reduce it through the sinus tarsi approach. I take the breast fragments outside and I construct it on the table, and I use fully threaded 1.2 key wires to reconstruct it in subcondylar bone to keep space for the definitive fixation. This is the picture after reduction. Here, this picture is hazy. This is after reduction through the sinus tarsi approach. With the upper part is the calcaneal, the talar tuberosity, talar tubercle, this one. This is the lateral fracture of Sander classification, and this is the medial one, and this is the Florov-Jessian angle. This is the best cortical read. And this is the immediate post-X-ray, and the Bohler angle is restored to 33 degrees. This is the missed wire, these fully threaded wires I used to reconstruct the articular surface outside the field. And this is the result after 4 years. I try to contact the patient sometimes because of financial problems. They refuse to come and repeat the X-ray. The patient I ask the patient about he returned back to work or not. He sent to me his picture while he's in a scaffold. He returned back to his work. The second case, this patient is 31 years old. He fell also from a scaffold, and he has bilateral displaced interarticular calcaneal fractures, joint depression type. This is the axial view, both sides. And this is the immediate post-X-ray. And this is the long-term results after 3 years. This is the axial view, both sides. And this is the patient gait after 3.5 years. This man is 45 years. He's a taxi driver, and he survived an RTA and developed badly displaced joint depression type interarticular calcaneal fractures with the posterior facet completely displaced medially, pressing on the neurovascular bundle. We shift the patient immediately. We couldn't feel the distal pulse, but the capillary filling was okay. We shift the patient from the casualty to CT scan and to the OR. This is CT scan. And this is a reduction achieved using the distractor and sinus tarsi approach. And this is the side of the incision about 4 centimeters. And these are results comparing to the other side. The dimensions of the calcaneus is almost restored. The osteoarthritis is inevitable with this high energy trauma, but the patient is happy with the results. He's returned back to his work. And this is his gait. The last case, this patient is 21 years old male. He jumped from somewhere, I don't know the exact history, he denied the true history, and he developed bilateral tongue-type fractures, badly displaced on the right side with blunter fragments. And this is a bilateral axial view. And this is this X-ray taken 140 days. I calculated the dates from the dates registered by the health system on the X-ray. And this is his gait. 140 days. And he traveled to Saudi Arabia and didn't see him back, just chatting through Facebook. He jumped. Yes. He was in Ward 21. Yes. Take-home message. Sinus Cersei approach. Through sinus Cersei approach, you can achieve anatomic reduction as the extended lateral approach for calcaneal fractures. But in addition, but the advantage is we can minimize the soft tissue complications. We have in Farani Hospital, we have 0% infection rate in minimally invasive management of calcaneal fractures. The other advantage is we can do definitive surgery on day one. No need to wait for a wrinkle sign or improvement of soft tissue condition. The use of distractor, I call it tireless assistant hand. You can use it to push the calcaneal tuberosity wherever you want and keep it until you put your preliminary fixation and then definitive fixation. It is a powerful reduction tool to restore the external calcaneal dimensions, which is essential in management of calcaneal fractures. As we all know, we need to restore the articular reduction, anatomical articular reduction, restoration of the external calcaneal dimension like the calcaneal length, calcaneal height, Bowler's angle, which has a prognostic significance. But over-reduction during distraction, I don't have any tool how to judge it, because especially if the patient has bilateral fractures. Even in unilateral, during distraction, it is roughly done. I don't know how to gauge it intraoperatively. I think we are still in need for robust evidence, like randomized controlled trial to compare operative and non-operative treatment, comparing well-matched cohorts of patients to reach definitive conclusion and to avoid or to correct the deficiencies or the flaws in the available literature till now. Thank you for attention. Last slide.
Thank you.
Thank you.
Thank you, Dr. Mtwali. So do we have any questions for Dr. Mtwali in his talk?
Okay, thank you for your lecture. I want to know what is the rule for blade fixation for these fractures? I think you always move the screws. What about the blades? And what about bone grafting? Do you need bone grafting for these fractures?
Regarding the first question, I have no experience in using blades through the sinus Cersei approach. I only used cannulated screws in addition to key wires, plus or minus key wires. But I have no experience in using blades. And I think there's special blades for this, like Tournier blade, which we don't have. But I am happy with doing only screws. Regarding the second question, I used graft only. The last graft I used was since 2013 through the extensile lateral approach, and the patient developed infection. And since that date, I didn't use it at all. And all these defects fill with time. After distraction, there's a big cavity in the calcaneus. All of them, during long-term follow-up, fill with cancellous bone. But I didn't use graft at all.
Okay, any other question?
Excellent cases, Dr. Just a question. When do you decide on doing an acute hindfoot fusion?
To be honest, I didn't try it. I kept it for Dr. Abdel Salam. He's doing primary fusion for Sander type 4 and comminuted calcaneal fractures. But me, I didn't try it till now.
Doctor, I noticed in some X-ray you have fully threaded K-wires. Or is that an artifact?
No, it's artifact. I use the fully threaded wires for reconstruction of the articular fragments only. To change it from Sander 3 to Sander 2.
From where we can get this wires? We don't have it in our hospital.
This is from Kuwait.
From Kuwait?
Yes.
Fully threaded K-wire.
But now it's not available. We used to borrow it from Razi Hospital.
Dr. Mitwalli, thank you for this nice cases. Our aim in calcaneal fracture to restore the lens and varus and the articular step off, okay?
Yes.
The point is you usually use the percutaneous technique, and this is accepted nowadays to avoid skin complication. But my point is, what is the size of screws you use it? 6.5, 7, 7.3?
4.5 cannulated screws, in addition to 3.5 for the transverse screws.
I think
in a lag fashion.
This is small. You can use larger diameter to take a big room.
I think to use 6.5 cannulated screws, the head is difficult to, even by force, you cannot borrow it.
You can sink it. Another question is, I saw some screws coming from up, down, and come screws from down, up. The coming from down, up, this will be potentially penetrate the joint. You have articular surface. I'm afraid from this. Also, the screw coming from up, down, it will be painful for the plantar fascia, either medial or lateral plantar fascia. Usually, I prefer to do a parallel screw as support, and then from the sinus tarsi, small screw like 3.5 to support the articular reduction.
Regarding the use of the head of the screws, I don't go through bluntly. Not from the blunter aspect of the heel, I go posterior inferior. It is away from the weight-bearing area. Sorry? Into the joint? No. The configuration of the posterior facet is saddle shaped. The most inferior part is medially. I used to confirm the articular reduction and the position of the screw with my eyes using the headlight and through prudence view. But regarding the head of the screw and the size of the cannulated screws, I never use 6.5, and I have only one case fractured, the broken screw, the cannulated one. Oh, but this is what badly displays the fracture was huge defect plantarly, and the patient most probably bought weight early. Only one case, broken screws.
Okay, I think we'll stop at this, and now we'll go with Dr. Ali Chirag, Assistant Professor at Kuwait University and Consultant Orthopedic in Jabir Hospital and Barak Hospital, and he'll be talking about distal humerus malunion case-based discussion. Yes.
It's not projecting. Okay, good afternoon, everyone. I'm happy to see all the audience. Actually, I'm thrilled of the number of audience today. So we'll shift from lower limb to upper limb, from acute trauma to chronic complication of trauma. So, what's happening? So today we'll talk about distal humerus osteotomy, inshallah, when the slides comes. So distal humerus osteotomy are procedures done to correct malunited fracture. And we don't see this much because most of this fracture happen during pediatric phase or during childhood. We see a lot of, maybe the pediatric doctors see a lot of supracondylar fractures are very common in pediatric population, or lateral epicondyle, medial epicondyle fractures. So today, We will discuss the indication of distal humerus osteotomy in adults. I will show in details one case that I have done with focusing on the importance of preoperative planning. As we heard from Professor Sharma, you should include the preoperative phase as part of your treatment. So the surgery start in the preoperative phase. Actually, you can spend more time in the preoperative phase than during the surgery. And then we'll go step by steps during this lecture on the surgical technique. So etiology of malunion, it can be hereditary, uncommon, but most commonly is post-traumatic. You can get cubitus varus, commonly with supracondylar fractures or overgrowth of the lateral epicondyle. Or you can get a valgus deformity if you have a vascular necrosis of lateral epicondyle, which is also common in pediatric, or supracondylar fractures, which is not as common as varus deformity. Or it can be iatrogenic. The surgeon put a screw, growth arrest because of the iatrogenic penetration of the growth plate. Do we do surgery? I think if you ask many people, they will not do surgery for simple cubitus varus. They will consider it purely cosmetic problem. This patient has no pain. Usually they don't have pain. They don't have restricted range of motion, and they don't have instability. What they might have, some ulnar nerve symptoms, and purely cosmetic most of the time. But if you have pain, instability, or problem with motion, then it is a mandatory procedure. It is very important before you do this procedure, you have to document the range of motion pre-op. You assess the ulnar nerve. I send all my patients to a nerve conduction study to document and protect ourselves if there is any existing problems prior to the surgery. You have to assess the joint stability, functional scores. You have to talk to the patient. What is his expectation? Does he want his shape to be better? Is it the ulnar nerve problem is making him problem? What he wants from the surgery, and ask him what do you do from the morning you wake up until you sleep, what type of activity he does, how many hours he stay in the desk, etc. So I have a case that I want to discuss with you. He's a 22-year-old male, right hand dominant. He had elbow deformity since age of 8 or 7 years old. Then I asked him, why you come now? Like, you come now after, now he's 26 and this has happened during your childhood. Why you come to me now? What was his response? That I'm getting married next year. I want to correct this because it's causing for me social embarrassment and I want to be in a better shape. So this is his indication. And when you compare to the left side, there is significant varus deformity compared to the other side. I actually, in the beginning, I refused. I told him I don't do cosmetic surgery. I referred him to another center to take another opinions, and all my colleagues agree that he does not need the surgery because he has no pain, he has minimal numbness, or maybe he's telling you, I have a numbness to get you, to convince you to do the surgery. At the end, he really insists, and he said, I want to sign for any problem, I'm responsible. I told him, fine, we can do it. So we started the surgery by counseling, and then we do x-rays. If you see X-ray on the left side, what you notice is the condyle is not perfectly circular compared to the other side. What does that mean? There is rotational problem also. It's not purely coronal deformity, there is some rotation. Then you should always get full length view with the joint above, the joint below. As we tell our medical student, you should assess the shoulder, the elbows, and both planes. Then you draw your joint line and epicondylar axis line. You can see there is some angulation on the affected side. CT scan just to make sure there is no other lesions or deformity. Then we start the planning. So the planning, we don't have a sophisticated software in our hospital. We do it on the old fashion, okay? Unfortunately in Kuwait, we don't have financial resources. Dr. Awad maybe will get us nice software. But on the right side, you can see there is the normal 16-degree physiological valgus, while his left side, where he's complaining, he has 15 degree of varus. So to get him back to the 16 of valgus, it's 15 plus 16. He needs 31 degree of correction, right? So I said, my plan A, always you have to have more than one plan. My plan A was to, if I do the surgery on paper and I remove a wedge, lateral closing wedge osteotomy of a 30-degree, will I get the correct alignment? The answer was yes, I can get a good alignment. I restored the angles, but I didn't like the way the plate will be bent. This is what we call lazy S deformity, or he will have a high lateral prominence index. It will be still the lateral condyle sticking and prominent. What about open wedge? We don't do that usually because of the problem with ulnar nerve. Okay, so he has ulnar nerve numbness, so it is actually contraindicated to do a medial opening wedge osteotomy. In this case, you go to the literature, you see what are the options. I found this technique in one of the paper, which called step cut translation osteotomy, which is a dome osteotomy, that you remove a wedge or a triangle from the distal femur, and you can rotate the whole distal humerus in two planes, in rotation and in coronal, to correct the alignment. And this triangle you can cut and use as a bone graft as well. And also you have to measure the lateral prominence index, which is A plus AB minus BC over the overall distance to know how much sticking laterally. So we did this procedure on paper, and I liked it. So if I cut a triangle, which is the orange part from the distal humerus, and I derotate the distal humerus back into the shaft, and this will give also some inherent stability, because this shelf or this triangle will have some inherent stability. So this triangle, you put it in a bag, in a sterile bag, you bring it with you to the OT to plan where is your location of the triangle. Then this is the pre-op picture. Patient was positioned prone. He was consented for clinical photography. He has written consent. So make sure if you want to take photos of your patient, you have a consent. We did exposure of ulnar nerve, and I isolate the ulnar nerve. Triceps splitting approach. If you notice that the olecranon is deviated because of the malrotation, you can see the direction of the split and where is the olecranon because of the rotation. Next step, you put the wires to define where you want to do your cut. So I put first wire is parallel to the shaft of the humerus, and the second transverse wire should be perpendicular to the shaft, not perpendicular to the joint, because you don't want, the joint is crooked or deformed. You don't want to cut parallel to the joint. So you can see the saw here on the far right is parallel to this wire. And then you use very small handheld oscillating saw to execute your plan, and you remove exact amount of triangle that you prepared in pre-op, which is, if you see, this is the amount on paper, and it's matched exactly in dimension, the amount of resected bone. And then after you remove that triangle, you compress, you do valgus by medialization of the distal fragment, and also you externally derotate the fragment and this representation. So you basically, you medialize and you rotate and you push the distal fragment inside the shaft. And then you fix it to two parallel plates. And then you correct the joint line. The red one was not perpendicular to the blue, but by the end, the red one is perpendicular to the blue one, and the osteotomy now is oblique line. So this is the immediate post-op. This is his clinical photography after the surgery. He's satisfied. Okay, and this is at 3 months. We can see some callus formation, and this is the last at 5 months with complete consolidation of the osteotomy. And he has this range of motion, which is almost complete because he has some limitation and flexion. So the take-home message is complex deformity around the elbow lead sometimes to chronic deformity and morbidity. Corrective osteotomy need very careful planning. You see, I spent maybe 1 week in planning, and I spent only 3 hours in surgery. So we did a lot of work before the surgery. Lateral closing wedge is still very popular with a very good result in pediatric population. A lot of pediatric surgeons, maybe they do closed wedge with K-wire and they have a good result. But for adult with multiplanar deformity, maybe a step cut osteotomy is a better solution. Thank you very much.
Thank you, Dr. Ali. So, any question for Dr. Ali? Yes, so Dr. Mukhtar.
Thank you, Dr. Ali, for this nice case. And also, the most important thing is preoperative plan.
Planning, yes.
Also, the second thing is decision to correct. The third thing, technique. You use double plating. You also explore the ulnar nerve. But my point is, in lateral plate, you are more up. You don't afraid to be near from the radial nerve, and you need to explore it in this situation.
I don't think it was so high, if I can go back. It's in front of me. I did tricep split. I'm on the shaft. So I didn't reach high enough. I don't think so. If I need to use usually supracondylar fracture or supracondylar osteotomy, you don't need to put the plate all the way up. But if you need, you have to explore. Any other questions?
Dr. Ali,
Dr. Najjar.
can do dome osteotomy, in this case, dome osteotomy?
This is like a dome osteotomy, but it has more inherent stability because you have like a triangle. You can slide the distal fragment inside the proximal fragment. So it is one of the type of dome osteotomy. Step cut osteotomy, it is kind of dome osteotomy.
Thank you.
Hello, Dr. Ali. Thank you so much for your lecture. I'm a physiotherapist, and I have a questions regarding to the functionality of this patient's post-operation. Did you restrict him from any lifting, heavy lift,
Yes.
or this kinds? I would like to know what is our limitation as a physiotherapist in your intervention. You and other colleagues, the surgeon colleagues, any interventions that includes implants, we would like to know our restrictions and our limitations when we apply our intervention as a physiotherapy.
Thank you. So it depends on how much we feel comfortable moving him. So for this particular case, because we have a good compression and double plating and secure fixation, for the first 3 weeks, I did not put for him a splint. I put only a bandage, and we used a hinged elbow brace. I told him there is no limitation, but you have to be in a brace, but you can flex, extend with unlimited range of motion. Regarding weightlifting, he was always asking me when he go back to the gym, when he can lift weight. I restricted this to 6 months. Okay. I told him you cannot do bench press or because I wouldn't risk it. He's also a heavy smoker, so he has risk factors of non-union. So, but now he's back in the gym. He's happy.
Yeah. So as a long term, he could.
Yeah, 6 months he can do whatever he wants.
Okay. Good.
Once we see a callus on the X-ray, callus means the fracture is united, and basically he can do whatever he wants.
Yes. Thank you so much.
The most important point in the question of the my colleague in physiotherapy, what about the elbow protocol physiotherapy? If we do rigid fixation, we can divide the protocol into 3 phases. Phase 1, phase 2, and phase 3. Phase 1 allowed to do active and assisted active. And this is 3 weeks to avoid heterotropic ossification. Then phase 2, you can start passive, also 3 weeks. And after this 6 weeks, phase 3, also 3 weeks, you can start weightlifting, lifting heavy objective, and with this protocol, you get proper range of motion without risk of heterotropic ossification.
Yeah, that's what we did. Yeah, first 3 weeks active, then passive, then for sure 3 to 6 months is weightlifting delayed.
Dr. Ali, thank you for this very interesting lecture. But I need to ask, in this new technique, we can correct the varus valgus easily.
It's not new. It's there in the literature since 90s. It's published by Korean surgeon. it's not new. I am not claiming that I did the new thing.
No, I'm not telling like that, but I'm telling it's easily to correct the varus valgus deformity.
Yes, yes.
But to how extent can we correct the rotation?
It's very easy.
Do we have evidence? Because in dome osteotomy, we have more, I think it will be more easier than this angle to correct the rotation during intraop.
Right.
So how do you pre-op planning regarding the rotation, and to how many extent can we correct the rotation intraop? Thank you.
Thank you. I don't have a figure of angles for rotation like in coronal plane because we planned it on a 2D, or we don't have a 3D software that can give you the rotation. But basically, I eyeballed the tip of the olecranon, where the tip of olecranon was in the beginning compared to the humerus shaft. I just make sure it's back on the midline. That's the way. But I agree, maybe it has some restriction. I've done maybe 1 or 2 cases. I have no great experience, but I think rotation can be easily corrected if you hold it pre-op, like the 2 epicondyles, and you see where is the olecranon, and then like the wire I showed you in the epicondylar axis, you can have an idea if you rotate it correctly or not.
So I think we'll stop there because we're already late. So thank you, Dr. Ali.
Thank you.
So now we'll go for our next talk with Dr. Al-Jarrah Al-Aidan. He's a consultant trauma and orthoplasty in Jabra Hospital, and he will be talking about case-based discussion. There's a slight change in the title of the lecture, so it will be thoroughly revision, case-based discussion.
Good afternoon, everyone, and thank you very much for your attendance. I have no conflicts of interest to declare. With regards to my scope of practice, I'm self-specialized in lower extremity trauma, as well as lower extremity reconstruction and arthroplasty. I'm going to start my talk today about talking straight into a case. So this case is a 14-year-old gentleman, or boy, who had, unfortunately, a history of a slip and fall while at school during walking. He came to our emergency department with this x-ray. So on the screen, you can see this x-ray, and he has a distal femur periprosthetic fracture just distal to his previously inserted nail. Upon history about this injury that he gave history of having a history trauma to his leg 5 months prior to this presentation. During that time, he was on a scooter and he was knocked by a car. He was treated at the time with an intramedullary nail. As you can see, it's a subtrochanteric fracture of his right femur. And looking at this x-ray, I consented the patient to sharing his images. You can see the technical challenges that you can face with this case given the big soft tissue envelope. So other than the obesity that the patient has, he is otherwise healthy. He did note that he had a history of having a post-op wound infection 1 to 2 weeks prior to his initial fixation. He also noted that he has ongoing hip pain over the past several months. And currently, he's obviously complaining of severe distal femur pain due to his recent injury. He also noted that following his surgery, he noticed that he had slightly increased external rotation of his operated side compared to his contralateral side. And he has been slow to mobilize. He's been using a wheelchair and a walker despite physiotherapy. On examination, his incisions are otherwise all healed. He has no signs of infection clinically. His pain is mostly around his distal femur, and just in terms of without causing him pain, he had approximately 2 centimeters of leg length discrepancy, with the right being shorter than the left. As part of any workup for a periprosthetic fracture in my practice, I have to rule out an infection. His preoperative blood work showed an elevated CRP with a normal white cell count. So with an elevated CRP, the question is, what do you do next? So going back to the patient's history, the patient complained of severe acute pain around his right femur. So based on the image that we have, we ordered more images, and this could be explained with the acute distal femur fracture that he has with these images. With regards to the pain that he has around his right proximal femur, the same CT was done, which shows possible either delayed union or possibly non-union. As you can see, there's a gap from anterior to posterior with no cortical bridging. So the question is, just to briefly touch on, what is bony union? So bone union is defined in many ways. There are many definitions, whatever you see fit in terms of your practice. It is generally when a fracture fails to heal or unite within the expected time. Now, the expected time is a very broad term. It depends on the patient's factors, whether they're young or they're old, depending on their multiple comorbidities, and obviously the type of injury that they have, as well as the location of the fracture that he has. The other thing that you have to keep in mind is if they don't heal, or if they're unable to heal without an intervention to help their healing. Generally, I tell my patients, whenever you have a fracture, it takes around 6 weeks for bones to heal. First, you get a fracture hematoma, followed by a soft callus, which then develops into a hard callus. This process takes 6 weeks in general terms. The FDA definition of non-union is 9 months and or 3 months of non-consecutive healing. Types of non-union, there are many classifications. The traditional classification is hypertrophic non-union and atrophic non-union. The hypertrophic non-union is when you have lack of mechanical stability when you have a fracture, and atrophic is when you have a lack of biology. For example, the patient is a smoker, there's an infection, he has a peripheral vascular disease, and then infection can occur in both. So there's a more recent classification talking about infection, but it can occur in both hypertrophic and atrophic non-union. In regards to managing non-union, I start with managing them by getting basic images and then further images to see a 3D reconstruction, a 3D image of the affected area. Blood work to check the infection markers as well as the metabolic workup. Identifying any modifiable risk factors. Is the patient a smoker? Is the patient a diabetic? Is the patient have anything that we can change to help with his healing? And finally, looking for any plan for optimal fracture stabilization. The traditional management principles is based on the type of non-union that you define after you do your preoperative workup. And in this case, we say that he has hypertrophic non-union and possible infection. The other thing that he mentioned is about the increased internal rotation that he noticed post-operatively. Unfortunately, we didn't have a bilateral CT of his lower extremities to check his rotational profile, but with these images, we can measure his anteversion. However, distally, it's difficult to assess the external rotation of the distal femur because we have more than one area in which the deformity can occur. It could either be the distal femur, or it could be the proximal femur, or a combination of both, which is why we just kept this idea at the back of our mind when we were working up this patient. So in terms of diagnosis of the current issues that we have an acute periprosthetic distal femur fracture. We have a delayed or non-union, depending on how you want to classify this, for his right proximal femur, and a possible infection. So my management for these is to stage them. First thing to do is to get a soft tissue confirmation of an infection. So you take him to the operating room, you do a soft tissue biopsy of the non-union site. Since you are there, you do an irrigation and debridement of the non-union site. And while the patient's under a general anesthetic, it's easier for me to assess his rotational profile of his unaffected side. So his left leg showed 80 degrees of external rotation and 10 degrees of internal rotation. The right leg is already fractured. We cannot assess it, so it's considered as an examinable limb. And finally, I was able to confirm the leg length discrepancy, which I had preoperatively, which was around 2 centimeters in length. Unfortunately, the soft tissue biopsy that we obtained was positive for staph epidermidis. It was sensitive to Cipro, Genta, and Vanco, and there were many pus cells. So once we had all the workup done, the thoughts that I had in mind, is the nail infected? Is the sample contaminated? Is there a role in doing an acute fixation with a potentially contaminated area? Can you ignore the nail? Do you have to revise the nail? What are the possible procedures that you're planning on doing? How many procedures? and what our goals are that we are trying to achieve. As you can see, that this is a very complex situation, so for me to dumb it down and to make it simpler, I break it down into a problem list. So with the problem list, I go back to the orthopedic principles. So number one, I have an acute periprosthetic distal femur fracture. There's a delayed union. There's a periprosthetic infection. Is there a component of derotation that needs to be done intraoperatively once the fixation is done? The patient is a skeletally mature patient, so he has open growth plates. And finally, the leg-leg discrepancy. I would strongly recommend my colleagues and anyone in this lecture, whether you're in your training or you're done with the training, in these complex cases, always talk to your colleagues and talk to your senior colleagues. I'd like to thank Dr. Uwaid and Dr. Ali Shaf for the preoperative work that we did and the ideas that we were bouncing back and forth preoperatively to see, is there a procedure or something that we can do to achieve a address to all these current issues without subjecting to more surgery. For my preoperative plan, the proposed plan was to do an irrigation debridement of his fracture site. Next thing is to extract the nail. Debride his non-union site. Usually whenever you have a nail, the medial cortex of the femur is blocked by the nail, so you cannot get a thorough decortication of the non-union site. I use an antibiotic cement-coated impregnated nail, antibiotic bone substitute at the fracture site, and then once I have my fixation, I assess their rotation intraoperatively to see if there's any derotation that needs to be done, and then fix his distal femur. So this is all part of the preoperative plan. I'm just going to briefly touch on the antibiotic-coated nail. There are many ways on how you can create one. There are many tips and tricks and techniques on how to make your own antibiotic nail. My preference is to use a chest tube. Unfortunately, in Kuwait, we only have a 36 French-sized chest tube. And I checked all hospitals. Unfortunately, we don't have anything bigger. So in the tibial nails, you can use a 36 because the inner diameter of the 36 is 8 millimeters. So you can get a coating of around 2 millimeters around the nail. With femoral shaft injuries where you have a nail of 11, 12, or possibly 13, you cannot get a 2 millimeter cement coating around it. Plus, you have a very smooth surface around the nail itself, so there's a less risk of incarceration as you put your nail down to the shaft. In terms of brief outcomes of this procedure, it has been described back in 2002. It's not something recent. There are only case series. There's no big randomized controlled trial that I know of. The reported success rate for the eradication of infection as well as the non-union is around 80 to 95%. It gives a high local concentration of antibiotics without the theoretical systemic side effects, even though I slightly disagree. There are case reports of having vancomycin toxicity because you're using more than the recommended dose. I generally use 2 grams of vancomycin powder with each 1 bag of cement. 1 bag is generally enough to create that cement mantle that you need. This procedure can be done both as a definitive fixation as well as a stage procedure. So let's say the patient comes with a reinfection, you can take out the nail and keep it. If the patient clears their infection, you can potentially leave the nail in because this cement mantle is done in similar to, for example, arthroplasty cases where you put a cement around an implant. In terms of complications, it's mostly related to either the cement debonding or if you have a persistent infection requiring revision surgery. In terms of revising a nail, my preference for revising femoral nails is always going lateral. My preference with, especially in this case, since he has a big soft tissue envelope, the initial procedure was a lateral entry, and I wanted to go with a more medial entry point. I use a lateral position for these nails. With the use of the C-arm, you can get proper AP images. However, it's always difficult to how to get your lateral images. I check the images pre-op before even draping. Once I'm draped, then I know that I get my proper images. Tips and tricks on how to get a proper lateral view is either putting them in a lazy lateral position or getting the C-arm to roll back 15 degrees to avoid the overlapping of the other femur to get better images. The gravity itself will help you by getting a more medial entry point. Most of the nails that you revise are lateral sided, so to get more medial, the gravity will help the reamer as well as the nail inserting to be in a more medial start point. This is an intraoperative image of extracting the previous nail. And once the nail was extracted, I used a 3.5 LCP plate to fix the distal femur provisionally, prepare the nail, and remap the canal. And once I'm happy with preparing the canal, I place 2 pins, similar to what was being described yesterday in terms of getting your rotational alignment, and fix the nail proximal. Once the nail was fixed proximal, antibiotic cement has been placed at the non-union site. And even though, as I said, the argument against using a lateral position is not getting an adequate image, you can see the femoral head clearly on a lateral position. Once I was happy with the fixation proximal, I then corrected the rotation after examining the patient, which was found to be around 20 degrees of excessive external rotation of his distal femur. Once the correction was done, I then flipped the patient supine to fix his distal femur fracture. With regards to fixing the distal femur fracture in an ischially mature patient, always take care not to cross the physis. My goal was to avoid fixation RIs to avoid fusing it. This is a 38 centimeter nail, which is just around the physial plate. A 36 nail would end at the fracture site, which would avoid us getting fixation distally. And these epiphyseal screws that you can see in the bottom are the vessel which can be removed at the 3-month mark. So this is the procedure where we performed post-operatively 6 weeks of IV antibiotics or oral antibiotics. So thanks to our infectious disease colleagues, they were able to help us with the choice of antibiotics. For him, it was 2 weeks of IV followed by 4 weeks of oral and early weight bearing. With a nail plate combo, I like to weight bear them as soon as possible. So special thanks to our physiotherapy colleagues. First 2 weeks, I do partial weight bearing just to make sure that the wounds heal. Once the wounds are fully healed, I progress into fully weight bearing at 2 weeks. The weight bearing itself will promote healing. These are his x-rays post-op day 1. You can see the graft is still in place and his distal femur fracture on this view. This is his 6-week post-op x-ray, which you can see increased callus formation around his previous previous non-union site, as well as dropping more callus around the distal femur. This is his 3-month mark x-ray with showing more callus proximal as well as more callus distal. A comparison of his post-operative day 1 and progressively all the way to the 3-month mark is seen there. And this is his distal femur. Unfortunately, as he started weight bearing, he compressed his fracture sites. I think that the nail has crossed his physis, so I'm going to assume that the physis is now fused, just given this x-ray. If I was planning on taking the epiphyseal screw, I think this might not be an option now. But we achieved union of his both proximal and distal fracture sites. In terms of him clinically, he's able to fully weight bear at 3 months with no walking aids. He has not been using a walker or a cane. Unfortunately, we have this discrepancy still visible with him laying supine. His rotational profile in resting position looks equal. With clinical examination, he's within 10 degrees of rotation on both internal and external of his right and left limb. So going back to the problem list, did we achieve acute fixation of his periprosthetic distal femur fracture? Yes. Did we treat his delayed union? Did we eradicate the infection? Was there any derotation required? Yes. The growth plates are now, in my situation, I think is sacrificed now, both proximal and distal. So the only thing that I'm left with now is a leg-length discrepancy. So a scanogram at 3 months now shows a discrepancy of approximately 2.3 centimeters, with the right being shorter than the left. The take-home message of this talk is preoperative planning. It has been stressed today more than once. Preoperative planning is extremely essential. I would recommend you trying to, even in complex cases, simplify it into just going back to the orthopedic principles and breaking it down to the principles. And identify and prioritize your surgical goals. My goal in this case is to eradicate the infection as well as achieve union. These are the 2 main things that I would like to achieve. The leg-length discrepancy could be dealt with in the future. And finally, make sure that you have a team-based approach in terms of your senior colleagues, your junior colleagues taking care of the patient intraoperatively, physiotherapists, infectious disease doctors, all to achieve this outcome. And thank you very much.
Thank you, Dr. Jarrah. So do we have any question for Dr. Jarrah? Any questions? Okay. So our next talk with Dr. Mishal. Dr. Mishal Hadood, and he will be talking about distal radius fractures, operative versus non-operative, who's taking the lead. And Dr. Mishal Hadood is a consultant of trauma and foot and ankle in Adan Hospital. Any questions in the meanwhile until the...
There is interview. أيوة. Yes.
تفضل دكتور مختار عنده سؤال. خلاص؟ اوكي تفضل.
السلام عليكم.
السلام عليكم.
So these are my disclosure, nothing related to my talk. A single mass common fracture in an adult less than 75 years of age are distal radius, and the treatment and prognosis continue to be unclear. Despite the prospective and randomized controlled trial in the literature, we still have not have a clear cut when decide to treat a distal radius, either operative or non-operative. So if we see this fracture, we might decide to go to fix it or just to leave it alone. But there is some reduction criteria for an intra-articular and extra-articular just to go through the fracture and x-rays, and then we decide for the operative treatment. Senior authors in 1980s, Jobiter and Gilberman, they did a great job in putting some criteria for the treating of distal radius. So one of the criteria is if you have a more than 2 millimeter stib or gap, the osteoarthritis for radiocarpal joint is high over time. But the problem is these studies has some faults. So what if these patients are older than 80 years? Because as we know, the current survival rate of age is more high these days. So the problem is with these studies are osteoarthritis described primarily in radiographics only. And both seniors remarked that lack of associated clinical symptoms. The late surgical intervention for a fusion or wrist arthroplasty are very rare. So the use of 2 millimeter intra-articular stib to justify a surgery in elderly is completely unjustified. Because these two seniors surgeons, they talk a lot in their podiums and courses about the results that they had before. So, Ternita in 2015, he published a predictor of failure. So one of the predictors are age. Shall I fix an 70 years old distal radius, intra-articular with displacement, treat him the same with 20 or 30 years old? Dorsal comminution. If you see in this X-ray, oh, sorry.
Just point into row.
Yes. Okay, so if you see in the lateral view, the dorsal chip, some surgeons, they take it very lightly. They say, oh, this is a small one, I can leave it alone, and okay. So if you see the small chip here in the dorsal side, in the lateral view, some surgeons, they just leave it alone. They say, okay, this is a very small chip, it will not affect the fracture, but believe me, down the road, the fracture, it will displace after the swelling comes down. And the third one is a volar reduction. The volar reduction is you have to have a cortex contact after reduction. If you see here, there is no cortex contact. So these are the predictor for failure of your reduction for a distal radius. So what's the evolution of the practice over time? Koval published a paper. It's a very nice one, actually. We tend to fix these kind of fracture more and more. And about 40 to 80% of these fractures being treated surgically. But the lack of surgeon perceived and a patient perceived of a functional outcome is still there. So, is there a bandwagon effect in treating a distal radius? I don't know. So let's go through some epidemiology just to have a clear, or remind us about the epidemiology of a distal radius. 90% of them are dorsal and 10% of them are volar. 50% of them are intra-articular. Type 1 more with the reckless young patients with high energy trauma, and type 2, which is old patients with low trauma. So if we draw a curve and we see the area under the curves, the type 2, it's a huge area, presentive more patients, osteoporotic, female. The anatomy of the distal radius still not changed. So Tunis, he revisit Milone's study, and he did some heat map, and if you see the red and the yellow area here, it's the fracture lines, and the blue ones are the pair area, let's say. There's no fracture happens in these area. Okay, so Tunis, he revisit Milone's study, and Milone says that distal radius comes with the 3 parts, and he proved it by a heat map. It shows in the red and the yellow area. Then Mandiak come back, and he want to study the fracture lines, where the fracture exit. So if you see here in the bottom two cadaver picture, you have the radial fragment. The radial fragments are the most displaced in the distal radius fracture. And the anteromedial part are the constant one. And the posteromedial part are the smallest one. So usually these are the fracture lines you see in a distal radius. And it's always almost exit outside the ligamentous area. So you'll never see a fracture in a distal radius go through a ligamentous area, and this is proved by this study. هذا مسكون.
Same problem is changing here only.
Huh?
Only changing in my screen. I think we'll go to the break to not to waste time. And after the break, Dr. Mishal will continue with his lecture, then we'll go for the pediatric session. So we'll have a 10 minutes break, please. Thank you.